Hi everyone, welcome to Imaging Study. Today we are going to start our weekly session about the ultrasound cases. I'm very disappointed because there's a huge noise coming around. I hope you are not getting a whole of the noise, but it's quite loud outside. So maybe you will be disturbed a little. I'm very sorry for that, but it's actually uh, quite very high. Okay, so anyway, let's just start. Don't forget to mention where you are actually from, and many of you are joining from different parts of the world. So we are very interested to know from which country you are joining and watching this content. So anyway, let's start with our main topic. If you are new to our program, my name is Dr. Mahin Ashraf. I'm from Bangladesh and I'm a radiologist. And we have a YouTube channel named Imaging Study, which already has crossed, fortunately, 64K subscribers. We have uploaded a few videos in our YouTube channel. And if you have missed our previous contents or previous sessions, you can easily get them in our YouTube channel. So all the videos are already available there. So don't forget to check them if you have missed them. So also you should subscribe or consider subscribing our YouTube channel, because why not? Anyway, let's start with our today's case. So we will discuss about 5 cases as like before, and I will just take around 1 hour of your time. So hopefully it will be beneficial for you. So let's start with the case number 1. There's a 42-year-old male patient who came too much noise around actually. So the patient came with back pain and lower urinary tract symptoms like urgency, frequency, whatever. Let's see what we have got on ultrasound. Here you can see we have taken the picture of the right kidney. It looks a little bit echogenic, not so much. But you can easily see there is a pelvic system dilatation. So there's a mild hydronephrosis here. And if you look here, you can see the proximal ureter on the right side is also dilated. So this is the right-sided mild hydroureter nephrosis. So we want to exclude the obstructive cause, because if you look at the left one, it also is showing the obstructive features. Like you see, this kidney has got moderately dilated pelvic system. It looks like a tree-like dilatation. Whenever you see a tree-like dilatation of the pelviureteric area or pelvic system, you should think about the moderate hydronephrosis or grade 3 hydronephrosis. Anyway, this kidney looks quite echogenic. If you compare the right one, uh, it's almost similar echogenicity as the liver, but in case of this kidney, apparently it looks quite echogenic because it has more obstructive like features. So we want to evaluate this lower urinary tract to exclude the obstructive features. So just look at the video of the left kidney. It looks quite echogenic, and you can easily see there is a hydronephrosis. But we try to search for any lesion within the kidney, but there was no lesion within the kidney. So as the ureter is dilated, we want to just go at the lower urinary tract to exclude the urinary bladder or urethra-related cause. So let's jump into the lower part. Here's the picture of the urinary bladder. You can see there is a cystic structure at the posterior aspect of the, oh no, there is 2 structures. You can see this is another tiny structure over there. So 2 tiny cystic areas are seen within the urinary bladder lumen at the posterior aspect, where there is the area for the vesico-ureteric junctions. So, any cystic lesion at the vesico-ureteric junction protruding into the urinary bladder lumen should be counted as ureterocele. So these 2 structures, this one is the largest one, and there is a tiny one here. So 2 structures, I'll show you again. So these are actually the ureterocele. That should be okay. Okay, this is ureterocele. You are making the diagnosis. You are having the hydroureteronephrosis. That's fine. But there is another feature over here. two features actually. You can see this is the distal ureter on the left side, which is also dilated. We'll see that again. But here you can see an echogenic structure, which is casting some acoustic shadow due to the machine presets, probe choice. This shadow is not well understandable, or this echogenic structure shape is not well understandable. You know, you need to adjust your frequencies, adjust your gain to see it well. So we have found something, but we need to evaluate it more. Let's see from a static image. Here you can see, this is one ureterocele. You can see it is connected to the ureter on the right side. And this one is the left-sided ureterocele, which is also connected here with the ureter. Now, if you look here, you can see they're changing their shape. Why they're changing? Actually, the urine is coming through the ureter, trying to enter into the urinary bladder, but these ureteroceles are causing a disturbance or obstruction. So that's why they're just getting like a balloon, they're getting dilated and trying to release some urine from this part. So they will change their shape. And as we see, the left one is quite more dilated and not changing the shape like the right one. It is changing slowly, actually. So this one, as it is a more larger in size, so it is causing more obstructive features. So you have seen that the left kidney has the moderate hydronephrosis and the echogenicity has already got changed. So these are due to this ureterocele on the left side. So let's look at the left one a little bit carefully. And now you can see an echogenic structure inside, which is also casting some acoustic shadow. So definitely there is a stone within this ureterocele. So this stone is not within the urinary bladder lumen. It is actually located within the ureterocele on the left side. And here you can see this is the distal left ureter, which is also getting connected to the ureterocele. So here is another view, and now you can see this is the right ureterocele. Oh, it's getting changed over time, so it is getting dilated. And this one is the left one, which is also having a stone inside. Let's look at the left one again, and now you can see this is stone within. So here's the picture. Now you can see this is the ureterocele on the left side, and there is a calculus inside within the left ureterocele. Okay, so this is the right one. You can see this ureterocele. Fortunately, when we were checking, the right one got collapsed over time and it again got dilated. So as it's changing its shape, it is just causing a mild obstructive feature. So you are getting mild right-sided ureteronephrosis. When it will cause more obstructive features, then you will get moderate or severe. Okay, so we use the 3D. Whenever you get this ureterocele-like thing, you should definitely use 3D if you have this facility, because it's quite easy. Now we have put the 3D transducer, just put a 3D button, and now you can see this is the urinary bladder lumen, and this larger one is nothing but the left-sided ureterocele, which is quite enlarged in size, and this one is the right ureterocele. Now you can't see the stone here because you're just looking at the surface of the ureterocele. So if you want to see the stone, you easily can use the skeleton mode of your 3D functionality. And if you use the skeleton mode, now you can see this tiny stone, which is now well understandable. So we have said that if you change the machine preset, the stone may be better understandable. So we have changed the preset. We used the 3D transducer or curvilinear volumetric probe, which has got a good resolution usually because it's expensive one. So now you can see this stone is well shaped and you can easily measure the actual diameter of this stone. So this is actually 1.6 centimeter and located within the left ureterocele. So here's the picture of the dilated distal ureters, and this is the right one and this is the left one. Obviously, the left one is more dilated because of that large ureterocele causing more obstructions. So this is a case of bilateral ureterocele causing obstructive uropathy, showing the right-sided mild and left-sided moderate hydroureter nephrosis with renal parenchymal overall changes. So there was a stone within the left ureterocele, which is an interesting finding because usually get stone within the urinary bladder or within the ureter, but it can also be impacted within the ureterocele. Okay, let's jump into the case number 2. So this is a recent case. I think it's from this Wednesday Wednesday case. So this was a 15-year-old male patient who came with a right lower abdominal pain. Now, an interesting question. If you face right lower abdominal pain, uh, where will you go? Will you go to the gynecologist? You're a male person. Will you go to the surgeon? Obviously, I would love to go for the surgeon or a medicine specialist, whatever. So this patient, a 15-year-old male with right lower abdominal pain, he went to a cardiologist. I was just amazed. Why a cardiologist here? So the cardiologist was expert. So he sent the patient to the surgeon. And the surgeon then did an ultrasound, which ultrasound showed there is only cystitis-like features, which is not actually a good thing. So overall, for some few days later, the patient was sent to a tertiary level hospital where he was got admitted to a medicine department. And then after one day, the medicine specialist sent the patient to the surgeon. But overall, the ultrasound reports were not satisfactory. And the last report say that there was a cystic lesion at the lower abdomen. So the patient was confused. The surgeon was confused because they need a definite diagnosis. Patient was having severe pain. So at the time, the patient with his relatives somehow came to our hospital, and that relative actually took that patient to me just to check what investigation he should go for. He was planning for a CT, but before that, he just saw me. So say that, hey, sir, please check this patient so that we can just send the patient to ultrasound or to the CT. So I was just closing my chamber, and at that time, I just checked the patient. So let's see what we have got on ultrasound. Here's the picture of the right lower abdomen. You see in the longitudinal section, this is the urinary bladder, and lateral to the posterolateral to the urinary bladder. Lateral, you should say. Here is a cystic area. But this cystic area doesn't look quite normal or quite comfortable for the patient. So you see, this is a irregular, thick wall cystic area with internal septations. You see internal low-level echoes. So you should definitely go for an abscess. Now, what is the origin of this abscess? This is a young patient. So in this type of situation, we actually go for two differentials. So these are very common. The first one is the appendicular abscess, which is common. And the second one is the psoas abscess. Psoas abscess may not be very common in your country, but for my country, tubercular abscesses are quite common. So we need to just evaluate from this image. Okay, so let's jump. Excluding psoas abscess is quite easy. You just check the psoas muscle. That's okay. So here we check the psoas muscle. It was completely normal, so we are not focusing on that. Now here is the lesion. It's an abscess. Now it's not a very big confusion. You see surrounding echogenic fat thickening, which is called the fat stranding on the other imaging modalities. So These are present here. So we are using the linear transducer right now, and on a slow image, you see the low-level internal echoes, some irregularities over here surrounding fat thickening. We checked the adjacent intestine. We couldn't found any appendix separately, and the gut motility was quite slow. So surrounding inflammation is quite obvious. So we took the color Doppler, and on Doppler, you can see there is a good amount of vascularity adjacent or at the wall of this lesion. So whenever you get a young patient with highly vascular wall, thick walled lesion with internal features of inflammatory collection, you should definitely think about an abscess of appendicular origin until proven otherwise. So we were focusing on the appendicular abscess. This patient has already gone 5 to 7 days with this situation. So definitely in a case of inflamed appendix without proper treatment, it may turn into an abscess within 4 to 5 days. So that is not a very uncommon case, and that happened here. Unfortunately, the patient went for 4 or 5 ultrasounds and all missed that thing. That's very sad thing, because it's quite common to make an appendicitis diagnosis in my country. It's very common, and nobody actually missed that thing. But this time, it was a holiday season, so somehow there was a neglected case this time by the family members, by the patient, and whatever. The patient is also very poor. And the interesting fact is that this patient is from my grandparents' area, which is also very remote area, and there is less imaging modalities available in that area. You even can't find any linear transducer in a big area, which is a very sad thing for this situation. Okay, so that's very unfortunate. Now you can see there is an increased peripheral flow on color Doppler. And this is an abscess on the right iliac fossa. So here's the picture of this large abscess in the right iliac fossa, which is very sad. And you see it's 9.5 centimeter in the long axis. So it's a big abscess. Very unfortunate. So here is the color Doppler picture. You can see there is a very big vascularity surrounding the lesion, because there is a whole inflammation going on there. So this is a case of right iliac fossa abscess, and possibly it's of appendicular origin, because we couldn't see any appendix separately. And obviously, this is the commonest one. Okay, so this patient, there is no, fortunately, this is today is Friday, I think. So, yeah. So I did this ultrasound on a Wednesday, and still there is no draininess done for this patient, because the clinician was waiting for the CT report, unfortunately. Okay. So anyway, case number 3, this is a 7-year-old male patient. Okay, so he came with a tip of the nose swelling. So it's not very uncommon. There is a reddish swelling at the tip of the nose. So let's see what we have got on ultrasound here. So here's the high frequency linear transducer view. And now you can see what you can see. This is the lesion. You see this echogenic area here? This echogenic part is the lesion. So whenever you see any superficial, just a slight lump-like feeling a lesion, usually congenital, getting enlarged over time. So the patient comes to you for evaluation, and you see this type of echogenicity, you just should put color Doppler. When you put the color Doppler, you will get the diagnosis. So let's see the structure, this one. So it will be ill-defined. The measurement won't be accurate on ultrasound. So MRI makes a good view, or extension evaluation is better on MRI, but ultrasound is best for the primary diagnosis. So let's put some color Doppler. Now on color Doppler, you can see it's not vigorously vascular, but you can still see a good amount of vascularity towards this lesion. You see some flow. Okay, so now what you need to understand, if you see the lesion having multiple venous channels, prominent venous channels, no definite good arterial flow, you'll go for the vascular malformation as a venous malformation. But here I'm not getting prominent venous flow here. I can see some venous flow, I can see some arterial flow. We'll check the pulse wave Doppler, obviously. So when you are getting a small arterial flow, small venous flow, within this type of homogeneously echogenic lesion, you should think about the hemangioma, which is more common, especially in case of congenital ones. So here you can see another view of the vascularity. You can see some arterial or venous flow. So we'll take the pulse wave Doppler that is needed. Otherwise, we can't say that. So here's the picture. You can see this vascularity inside this echogenic lesion. And now on pulse wave Doppler, we checked. We can see there is an arterial flow. You see this type of wave patterns are from the external carotid arterial wave pattern. So the lesion is getting supply from a branch of artery, which is also a branch originated from the external carotid artery. So usually in this side, we get the facial arterial branches, and that is obviously a branch originated from the mother branch of external carotid artery. Okay, so this is wave pattern is quite similar to that. Anyway, so you can see a good amount of arterial flow of 19 centimeter per second, and there is a venous flow. You see this prominent vessel, but it is a vein. So when you are getting an arterial and venous flow, it is homogeneously echogenic. There is a history of congenital type and getting enlarged over time. You go for the hemangioma. So this is a vascular malformation at the tip of the nose, and possibly it's an hemangioma. Okay, case number 4. So many people are watching, so don't forget to make a comment in the live video, because I'm not actually watching the posted ones, because I have posted shared this video to many different groups. So if you are watching it from any different group, just try to make comment on the live one, because the live one is open in my mobile right now, so I can just see what you are actually commenting here. Anyway, so don't forget to comment your location. That is very valuable for us, because we enjoy seeing people from different part of the world getting connected for just 1 hour in our channel. So let's jump into the case number 4. This is a 35-year-old male patient who came with a left wrist swelling. I actually don't love musculoskeletal ultrasound, but this time I was facing a patient who came to me with this feature. And interestingly, in a single week, I got 3 or 4 patients with similar features. I was very confused, and that might be due to the viral cause, I think, which is not uncommon also. Anyway, let's jump into the ultrasound features. So the patient had a swelling over this area, so dorsal aspect of the wrist. In this type of situation, I commonly see patients coming with a ganglionic cyst, which is common in the wrist area. But in case of ganglionic cyst, you get a dome-shaped dilatation, a dome-shaped lump. But this patient didn't have a dome-shaped swelling. It's just a swelled up area over here. So first time with the history, I thought, oh, okay, I'm getting a case of ganglionic cyst. But when I saw the patient, I was confident that this should not be a ganglionic cyst. So let's see what we have got on ultrasound. Here's the high frequency ultrasound view. And now you can see on the cross section over the this is the lateral aspect. So lateral aspect of the dorsum of the wrist. You can see this is a tendon over here, and this tendon is surrounded by a collection. You see this collection, anechoic collection. So whenever you see a tendon with a very smooth surrounding collection, making a very good view, these are due to the tenosynovitis. Now, it's quite easy to diagnose a tenosynovitis just looking at this view. And in the dorsal aspect of the wrist, this is the extensor area. Extensor tendons are here. So this is quite common. and you easily can diagnose. But the problem is that you should know which tendon is this one. So here is another view, and we are just looking at this tendon. Just wait a little bit. So here's the one, and you can see there is a surrounding collection over here. This is the lateral aspect. So two tendons are over here, and it has good surrounding collection. So in the extensor compartment, we have got actually some 6 compartments here. And this one, for this patient, it was the radial side, and it was the most lateral aspect. So we call it the compartment 1. And so the tendon you saw was the compartment 1 tendons. And sorry, little just let me just silent my phone. Okay, so these tendons were the abductor pollicis longus and extensor pollicis brevis. I always forget these names, so it's easy to remember. This is the compartment 1 tendons, this is the compartment 2, and so we can just easily divide them. Anyway, I won't go deeply for these things, but it's quite easy when you get them. So anyway, so we are just watching the compartment 1 tendons having tenosynovitis. So this one, you can see the tendon in longitudinal section. You can see surrounding the fluid and some synovial thickening also there. You can see, just let me freeze the image. Okay, so here you can see some hypoechoic thickening areas. So these are actually the synovial thickening, which is also present here. So anyway, you can see some collection and synovial thickening, which indicates this is a case of tenosynovitis involving the compartment 1 tendons. So this is the compartment 2 and 3. All these tendons are seen like groups. So it's not very difficult. You can just count and just go from the lateral to medial, and you can just find 6 group of tendons. Okay, let's put some Doppler. This is very important because in case of tenosynovitis, you will get a good amount of vascularity. So here you can see some crazy vascularity surrounding this tendon. So the synovial vascularity has got increased. You may even see the vascularity within the tendon because all the area is involved in inflammatory process. So there is a good vascularity. So let's look at the longitudinal section. You can see, make sure there are some vessels over here. So don't forget to check those vessels and making misdiagnosis as the large vessel as the tendinous vascularity. So in transverse section, you can easily differentiate which one is the major vessel. Like here, you will see the radial artery and its branches. So you can easily differentiate that. So here you can see on the transverse section, this compartment 1 tendon and the surrounding fluid collection with some synovial thickening indicating tenosynovitis. So here's the color Doppler picture. Now you can see some vascularity surrounding it. This one is the vessel. You see, this is the good large vessel because you can see the cephalic vein and some vessels are entering in this part. Okay. So this is a case of tenosynovitis of the left wrist involving the extensor compartment 1 tendons. Okay, my surrounding noise has gone. So now I'm feeling a little bit comfortable. Okay, so let's end with the case number 5. This will be a pregnancy case, obviously. And in recent days, I'm getting some cardiac abnormality patients. So I'm just not getting happy with them. But yeah, okay. Just let me check my internet a little bit. Somehow my one phone has got collapsed, so I'm just changing the internet connection because I can't see the live right now. Okay, so yeah, it's here. Okay. I don't know why my connection was gone. Anyway, let's just jump into the session. Okay, so net connection is quite okay. Yeah. So this is a 38-year-old female patient who came with 9 months of amenorrhea, and there was a suspicion of the fetal cardiac abnormality. So let's see what we have got on ultrasound in this case. Just let me change my internet connection for just a while. Okay, sorry for the interruption. Yeah, yeah, no, it's okay. Okay, let's jump into the case number 5. In this patient, patient went for some ultrasound, and the patient was suspected as some cardiac abnormality, and obviously the abnormality on the right heart. So let's see what we have got on ultrasound here. So here's the picture. Now you can see the measurements, and it looks around 34 weeks of gestation. Some measurements are not just matching with the others. The femoral length is quite shortened to 32 weeks of gestation, but the bipetal diameter or abdominal or head circumferences have shown that they're around 34 weeks of gestation. So there is a discrepancy you can see. So you need to evaluate the further causes. So let's jump. So here you can see the glimpse of the heart, and just looking at that heart, I just understood that it will take a big time for me to make the diagnosis. So here you can see the heart looks quite enlarged. It's just occupying the chest, and you can see the mitral valve is jumping, but there is something abnormality going on the right heart. Here you can see the foramen ovale is jumping, so it's not a good sign. So let's use the cardiac setting to see the heart quite well. Now on primarily, you can see it's not a good view, but still you can see the mitral valve is pumping. But here you can't see any movement of the tricuspid valve. Okay, and this is the foramen ovale here, and you can see there is a bulging from the this right side to the left side. So this bulging indicates that there is a atrial septal aneurysmal dilatation or atrial septal aneurysm, which we commonly see in case of tricuspid atresia or tricuspid stenosis. So we'll need to evaluate the tricuspid valve in this patient. So the patient was sent to us that with noting that there was a right ventricular collapse or right ventricular not understandable situation. The four chamber view is not quite good or understandable. So we need echo. And now you can see the right ventricle. Yeah, there is the lumen is completely collapsed or something like that. We'll use the Doppler. So many things to evaluate here. So let's magnify the image. And now you see the mitral valve is pumping very good. I don't have any objection about that. But if you look here, this is the left ventricular wall. It is quite thickened. If you compare it with some normal fetal heart, this one is thickened. And if you look at the interventricular septum, it is also thickened. It's not in normal cases that type of thick. And if you look at the right ventricular wall, it's also thickened. But the difference between the right and left ventricle is quite obvious. You can see the left ventricular lumen, but you can't see the right ventricular lumen. So now, if you can't see the right ventricular lumen, you need to evaluate the tricuspid valve. So here's the tricuspid valve. You can see it's moving. It's not just stopped. It's moving, but you can see a tiny lumen. I just see here. Let me freeze the image. Just go a little backward. Yeah, this one is the right ventricular lumen. So it's not a good lumen. It's just like a orifice, you can say. It's not a lumen. So the tricuspid valve is trying to move actually, but it can't actually forcefully push the blood from the right atrium to right ventricle. Now, as the right ventricle is trying to push and whatever it's trying, so it's just having a thickened wall and the collapsed lumen. And overall, the pressure is getting generated to the right atrium. So it's just pushing the blood to the left atrium. And that is actually causing, there is a atrial septal aneurysmal dilatation or atrial septal aneurysm. So many complicated situations are going on here. Okay, so let's look at this area from different view. So as the right ventricle is not getting the blood, so what will happen about the pulmonary trunk? Make sure in this type of situation, you need to make a very good comment about the pulmonary trunk. So if it is stenosed or narrow, then it may actually disturb the patient. So now the question appears that if the pulmonary trunk is narrow or getting narrow, or where the pulmonary trunk is getting blood from, because right ventricle, it looks like it is not capable of putting the blood into the pulmonary trunk from this lumen. So in this type of situation, usually the pulmonary trunk gets blood retrogradely from the ductus arteriosa. So it gets blood from the aorta, and from the ductus arteriosus, it goes to the pulmonary trunk, and then it goes to the lung. So this is not a very good condition, because when the baby will get birth, there will be an increased demand of blood to the lung, and at that time the situation will worsen and the baby will die. So let's look at the color Doppler. Ignore too much difficult talks. So here you can see very good inflow, outflow, whatever you say in the left side. But on the right side, you see the situation is not quite good. Let me freeze the image. You can see this is the atrial septal aneurysm. So just go here. This one is the tricuspid valve flow. So there is a flow in the tricuspid valve. So it is not atritic, actually. It should be the stenotic. So it's not functioning quite well, but trying to function. Okay, so now you can see some aliasing flow here that is definitely due to the tricuspid regurgitation, which should be present here because you are trying to push the blood into the right ventricle, but the right ventricle is not capable of capturing those blood. So there will be a tricuspid regurgitation from that part. Okay, so yeah, just see here, very small, just a narrow flow through the tricuspid valve into the collapsed lumen of the right ventricle. So yeah, you see this one. So in case of fetal echo, you always have to freeze the image, just go backwards and forwards and just try to make the diagnosis. I was actually searching for the uh, ventricular septal defect in this patient, which is not present here, but I tried to look for them. Anyway, you can see the right ventricular wall is very well thickened here. Okay, let's jump into the next picture. So here is the atrial septal aneurysm, which is quite obvious here because the right atrium is having a very big pressure, so it is pushing the blood. Now, you know, the right atrium is getting blood from the supervena cava, inferior vena cava, right? So as it is getting blood from the right superior inferior vena cava, and inferior vena cava is getting blood from the hepatic veins. There is a connection of the ductus venosus also. So as there is a big pressure over here, so you should definitely get some flow changes in ductus venosus and umbilical vein. So you need to check the umbilical vein and ductus venosus in this patient. So we'll check them. Okay, so here you can see we have just took a picture of the pulmonary trunk here. This is the pulmonary trunk. This is the ductus arteriosus entering into the descending aorta here. So it is quite prominent, but you see the pulmonary trunk, its branches here. So they are quite narrow. I will show you the measurement on a different picture, and there is a glimpse of aorta, I think. So we'll see that. So here's the picture. Now you can see this is the left atrium, left ventricle, right atrium and right ventricle. Right ventricle is lumen is collapsed, and you can see this is the tiny tricuspid valve flow, which is also getting regurgitated, obviously. Okay, so this is the glimpse of the pulmonary trunk and the aorta, ascending aorta. Now you can see the aorta is quite dilated in comparison to the pulmonary trunk. And obviously the pulmonary trunk will get the regurgitated flow. On color Doppler, you can easily understand that. Unfortunately, I couldn't actually, or I forgot to save that image. So you will see the regurgitated flow from the ductus arteriosus towards the pulmonary trunk. So I tried to measure the chest with just manual method. I didn't take the circumference, and obviously the heart is quite enlarged. Whenever you're seeing at the heart, you're just know that the heart is enlarged, then you get the measurement. So we never actually measure the heart to say it a cardiomegaly. We measure the heart because it is a cardiomegaly. Okay, so let's look at the umbilical vein. It is showing you the pulsatile flow, which is unusual. uh, and if you look at the ductus venosus, not a good view, but you still can see there is a regurgitate flow here. And this large reversed A wave indicates there is a good amount of, or there is a high right atrial pressure there. Okay, so what about the umbilical artery? Umbilical artery is not showing a good flow. There is a high resistive flow within the umbilical artery. You see the diastolic flow is getting reduced, which is not a good feature. But the middle cerebral artery was giving a good amount of flow. Yeah, it may look quite normal, but it is not should be counted as normal because all the vessels has got changed. So you are getting a low femoral length. It indicates the growth is getting diminished. So in this type of situations, whenever we get a normal middle cerebral artery, we should get careful because this is also a feature of cerebral edema. Okay, so another point in favor of the bad condition of the fetus, you see the amniotic fluid volume is getting reduced. The amniotic fluid index is around 7.5, which is also getting reduced over time. So just 2 weeks ago, the amniotic fluid volume was quite normal as far we understand, we saw on previous reports. Okay, so this was about around 33 to 34 weeks of single live intermittent pregnancy with cephalic presentation and mild oligohydramnios. And many of you follow many different charts and different measurement techniques to say it an oligohydramnios. Remember that there is a very common three techniques to say oligohydram, the normal amniotic fluid. One is the amniotic fluid index, which is followed as 8 to 24 centimeter normal in our subcontinent or in our country. Or in some countries, we follow the 5 to 22, 5 to 20, many different measurements techniques available. In case of RUMAC, if you follow RUMAC diagnostic ultrasound, there is written as 10 to 20. We usually have a chart, age by age chart, so you can easily follow that. Okay, and the second one, the second measurement tool is the single deepest pocket measurement, which is commonly said as 2 to 8 centimeter normal. And the third one, most important one, said by the books, are the visualization. So remember that for amniotic fluid measurement, visualization is much more important than any other measurement. So what you see is more important than what you measure because the measurement is given by the machine and the visualization is given by your brain. So just have some brain. Okay, so let's look at the fetal cardiac abnormalities. The patient had tricuspid valve stenosis. We had a stenotic flow, and obviously there was a regurgitation and a collapse right ventricle. We saw cardiomegaly with thickened ventricular walls, both side ventricular walls, because the left ventricle has is having more pressure, more work, so it's also getting thick-walled situation. And there was a narrow pulmonary artery with there was a regurgitant flow through the ductus arteriosus, which is supplying the pulmonary trunk and the lung. And obviously, after birth, this situation will be worsened because the pulmonary trunk, if they use the ductus arteriosus and aortic flow to supply the lung, the situation will be devastating and the baby will die shortly. And there will be an atrial septal aneurysm present here. Okay, So that's all for today. And yeah, thank you for watching this content. And yeah, we have our next session on the 18th April 2025. It should be on Friday, next Friday. And we'll try to show you 5 interesting cases if possible. And don't forget to subscribe our YouTube channel. We have already got 480 videos and 64K subscribers. That's thank you very much. Thank you. I was actually, when I started my YouTube channel, my targeted goal was 20K subscribers. That's true one. And now, fortunately, when I see the subscriber amount is 64K, so I feel very confident and I feel very thankful to you. So that's why I'm trying to make this type of content for you every Friday. Anyway, hopefully this will be helpful for many of you, and many of you are wasting your time just watching that. So we also have a uh, just not used website named imagingstudy.com. I wish I would just use that for any time in near future. Anyway, thank you for joining us, and hope to see you soon. So if you have any question, you can just put that down in the live part. And yeah, we'll upload this. If you have missed the previous parts or this video from the starting point, this video will be saved in our Facebook page, and also obviously we'll upload this video in our YouTube channel tomorrow. Just let me check. Yeah, there is an important question here. Why the gallbladder stone not showing twinkling artifact? If I say you about my machine, in my machine, I can't actually see the twinkling artifact on a tiny stone, even for the ureteric stone with my transducer. But if I change it to the renal setting or a contrast image setting, then I can get that. So it depends on your preset. It depends on which frequency you are using, which transducer you are using. And again, for twinkling artifact, you need a tiny structure, you need a pointed structure. So the large stones won't actually show you the twinkling artifacts. Okay, yeah. So you asked for the bonus part on varicocele. I'm not actually making bonus parts for a long time. Today I had a plan, but unfortunately I was busy whole day, just for some family reason, or just making something good for this my studio setup. Anyway, so that's why I couldn't actually get time. So I started making this presentation just 1.5 hours before this starting time. So just within 1.5 hours, I made this thing. So I didn't get much time. So next time, obviously, I'll try. Varicocele is a very important thing. Nowadays, we go for the Sertesi classification for the testicular varicocele. We see many different types of reports. We see many different types of classifications. But nowadays, in my country and I think my nearby countries, urologists also follow the Sertesi classifications, and it's quite easy. So we'll try to share that with you. Okay. Right now, very few people are connected here. Okay. Okay, anyway, if you are connected here from my country, I have stopped my paid sessions for a long time, and we have a plan to restart those sessions from this week, possibly from the Tuesday. But I have got a lot of patients nowadays after the holiday, and it's just getting too much disturbed. So I'm getting too much tired to take some sessions at the evening hour. But hopefully in recent days, I will just restart those paid sessions. So I will notify in my profile and my pages. So just get connected there. Anyway, so thank you for joining everyone, and hope to see you on our next session. So till then, thank you. Thank you for joining. Have a nice day.